7-hydroxymitragynine from Kratom Withdrawal. Clear science-based case for clinicians and non-clinicians. A 48-year-old woman stopped a potent kratom component called 7-hydroxymitragynine after several weeks of daily use. Within about 2 days, she developed fast heartbeat, shaking, anxiety, and severe restlessness. A standard anti-anxiety medicine did not help. A medicine used to treat opioid withdrawal, buprenorphine combined with naloxone, quickly reduced most symptoms. A 48-year-old woman. A 48-year-old woman with self-directed use of 7-hydroxymitragynine for several weeks to about 1 month. The last reported dose was a short interval before seeking medical care. No other daily substances were reported. What does this mean? She had been using a strong kratom-related product every day and then stopped suddenly. 7-hydroxymitragynine is an alkaloid found in kratom and in many concentrated kratom extracts. In laboratory and animal studies, it primarily activates the mu opioid receptor in the brain, similar to other opioids, and can produce pain relief and euphoria. With repeated daily use, the brain adapts. Stopping suddenly can cause an opioid-type withdrawal.
Why this matters? Because the brain changes with regular exposure, the correct treatment for the resulting withdrawal is an opioid-focused approach, not only anti-anxiety medicines. One, how did we decide the diagnosis? Most likely diagnosis: opioid-type withdrawal from stopping 7-hydroxymitragynine. Reasoning for and against alternatives. For opioid-type withdrawal, recent daily use with abrupt stop. Classic symptoms: rapid improvement after buprenorphine. Against alcohol or benzodiazepine withdrawal, low blood ethanol level, no convincing history of heavy daily use, minimal effect from diazepam. Against infections or thyroid storm, normal temperature, normal white blood cell count, normal lactic acid, and the time link to stopping 7-hydroxymitragynine. Against serotonin toxicity, no fever, no muscle clonus, and no overactive reflexes.
Ethanol, 10 mg per deciliter, clinically trivial. Serum sodium, 137 millimoles per liter, normal. Serum potassium, 3.7 millimoles per liter, low normal. Serum chloride, 102 millimoles per liter, normal. Serum carbon dioxide, 21 millimoles per liter, mildly low, consistent with fast breathing. Blood urea nitrogen, 6 milligrams per deciliter, low. Serum creatinine, 0.57 milligrams per deciliter, normal kidney function. Serum glucose, 128 milligrams per deciliter, mild stress elevation. Calculated anion gap, 14 millimoles per liter, upper normal. Total serum calcium, 9.9 milligrams per deciliter, normal. Serum magnesium, 1.5 milligrams per deciliter, mildly low. Aspartate aminotransferase, 26 units per liter, normal. Alanine aminotransferase, 16 units per liter, normal. Hemoglobin, 14 grams per deciliter, normal. Platelet count, 394,000 per microliter, upper normal. White blood cell count, 9,000 per microliter, normal. Lactic acid, 1.9 millimoles per liter, normal.
Why these matter? There is no sign of infection, organ injury, or low oxygen. The only clear fixable issue is low magnesium, which can worsen tremor and make certain heart rhythm problems more likely.
Buprenorphine with naloxone by sublingual route to treat opioid-type withdrawal. Buprenorphine is a partial agonist with very high receptor affinity at the mu opioid receptor. It eases withdrawal and cravings while lowering overdose risk compared with full opioid agonists. Supportive environment and monitoring. Quiet room, reassurance, and continuous heart and oxygen monitoring. Trial of diazepam by intravenous route for agitation. Minimal benefit, which further supports an opioid-predominant withdrawal rather than a gamma-aminobutyric acid withdrawal state. We treated the cause, opioid-like withdrawal, kept her safe, and watched her closely. Continue symptom-guided buprenorphine naloxone. Reasonable inpatient ceiling day 1 up to 24 mg, including the prior 16 mg. Once stable, consolidate to a single daily maintenance dose, commonly 12 to 24 mg per day. Caution: combining buprenorphine with alcohol, benzodiazepines, or other sedatives can slow breathing. Use only with careful oversight.
For autonomic symptoms and sleep, clonidine 0.1, 0.2 g/po every 6 hours. PRN for tachycardia, sweating, or restlessness. Hold if systolic BP 100 mmHg or heart rate 60 bpm. Ondansetron 4 mg/po or IV every 6 hours. PRN for nausea. Trazodone 50 mg/po at bedtime. PRN for insomnia.
If severe agitation persists despite adequate buprenorphine, consider a dexmedetomidine infusion in a monitored setting to calm sympathetic overactivity without suppressing breathing. Droperidol IV 0.625 1.25 ml may help akathisia-like restlessness. Obtain an ECG before and after and correct magnesium and potassium first. Correct fixable contributors. Give 2 grams magnesium sulfate IV, then recheck. Aim for serum magnesium 2.0 mg/dl. Optimize potassium with a goal of at least 4.0 mmol/L. Give isotonic fluids as needed for comfort and mild dehydration. Keep continuous cardiac monitoring and pulse oximetry until resting heart rate remains below about 100-110 beats per minute and agitation settles. Repeat electrocardiograms if droperidol is used or if a fast heartbeat persists. Recheck basic metabolic panel and serum magnesium after repletion and again before discharge.
Disposition and harm reduction. Admit for stabilization. At discharge, provide a 7-day buprenorphine naloxone prescription at the effective daily dose. Give a naloxone rescue kit, and schedule addiction medicine follow-up within 1 week. Offer screening and vaccinations as appropriate and counsel on relapse prevention and avoiding mixtures with sedatives or alcohol.
How did the numbers change with treatment? Heart rate moved from 156 beats per minute to about 110 after buprenorphine, with continued improvement expected as withdrawal eases. Results update. Serum magnesium was 1.5 mg/dl and is improving with repletion. Serum carbon dioxide and the anion gap are normalizing as symptoms settle. Liver and kidney tests are normal and stable. No dose adjustments are needed for buprenorphine. Regular exposure to 7-hydroxymitragynine keeps the mu opioid receptor repeatedly activated. The nervous system adapts by turning down its own calming chemistry. When the substance is suddenly removed, the system rebounds in the opposite direction, producing a surge in sympathetic nervous system activity, fast heartbeat, tremor, sweating, anxiety, and the feeling of inner restlessness. Buprenorphine partially stimulates the same receptor with very high binding strength. That stops the rebound, eases symptoms, and blocks other opioids from attaching, all while limiting the chances of slowed breathing compared with full-strength opioids. Short-term outlook. Excellent with ongoing buprenorphine-based management and supportive care. Most patients stabilize over the next 12 to 24 hours. Long-term outlook. Good if she remains engaged in medication for opioid use disorder, plus counseling and recovery supports. The relapse risk is real with kratomextracts because product strength is highly variable and often not well regulated.
Kratom products, especially concentrated extracts, can contain unpredictable amounts of 7-hydroxymitragynine or related compounds. Strength can vary widely from dose to dose. The combination of kratom or 7-hydroxymitragynine with alcohol, benzodiazepines, or other sedative medicines increases the risk of dangerous sleepiness and slowed breathing. If the decision is to stop kratom-related products, medical support with buprenorphine is often the safest and most comfortable path.
Stopping 7-hydroxymitragynine after daily use can cause significant opioid-type withdrawal. Expect fast heartbeat, tremor, anxiety, and restlessness within about 2 days. Treat the physiology, not just the anxiety. Buprenorphine with naloxone is the cornerstone. Sedatives alone will not resolve the underlying withdrawal. Correct low magnesium and monitor the heart if using medicines that can affect heart electrical activity. Plan the exit from the hospital on day 1. Provide a short bridge prescription, a naloxone rescue kit, and a rapid addiction medicine follow-up appointment. Educate about kratom variability. Extract potency and composition are inconsistent. Medical guidance reduces harm. A 48-year-old woman experienced opioid-type withdrawal after abruptly stopping 7-hydroxymitragynine. Buprenorphine with naloxone rapidly improved her condition, while supportive care, electrolyte correction, and close monitoring ensured safety and set up a solid plan for recovery.